Good morning, everybody. I would like to congratulate Dr. Palma-Shah, the current president of the ICVS, and the entire organizing committee for putting together this wonderful program. So, good morning, everybody. We're going to talk over the next few minutes regarding the endovascular repairs for ascending aorta as well as Endo-bentall. This is my disclosures. So everything that we're going to talk about is off a multi-label. There's no FDA arch endograft and ascending aorta device approved. All these are minimal invasive alternatives, and the reason is to be able to offer to patients unfit for an open repair the better actually solution. So you can see here that the first endovascular repair for type A dissection was described in 2012 by Matt Thompson group and colleagues. And at that time, in 2012, so he described the Geneve ascending dissection stent here for a localized ascending dissection. And this is 2 years later when we actually published 7 of our patients when I was here in Houston with patients had hydrogenic coarctation as well as pseudoaneurysm. And this is an excellent review by Marvin Atkins colleagues for the endovascular management of the ascending aorta, and he described 3 grafts. Again, none of this is approved in the US yet. The ascending stent graft was in trial. We described the Terumo aortic and the Cook ascending. And you can see over the last decade, actually, but definitely over the last few years, there's multiple reports regarding the endovascular management for ascending aorta. This is the 2 systematic reviews, 118 patients, mortality 15%, conversion to open repair in the CVA, adverse events 3.4%. Again, this is high-risk patients, as you can imagine. This is another review. 10% of the patients were unfit for an open repair. Great technical success, 30-day mortality 9%, stroke 6%. Not actually bad for patients that can be extremely high risk for any open repair. And this is the 2 actually papers that came out, the original papers from the RI's trial. Both Methodist and Texas Heart were actually part of this trial, and we actually was among different centers, and we presented the results for the first in human novel stent graft for the ascending aorta. So regarding the Endo-bentall, this is something new that is coming down the pipeline. A few reports in the literature that are coming more and more for the last maybe like 2 years or so. You can see here in 2022, Wilson, Zitton, and colleagues from Penn. The question is Endo-bentall feasible, and we can see a year later from Bradley Leschnauer from Emory and colleagues, where they use the Cook-Zenith thoracic graft. They modify it. They place the 2 fenestrations for the coronaries. They introduce the endograft via the left common carotid, partially deployed, and also they cannulated the coronaries with the VBX. And this is the first in human type A aortic dissection performed at the University of Maryland by Merad, Gorici, and colleagues. Was published recently, and where he put together the valve with the graft. He actually sutured it together, created fenestrations similar to the fenestrations that we use for the thoracoabdominal grafts. And you can see here the coronaries. Then he resheathed the graft the same way that we used to resheath the graft a long time ago. And then he delivered it. So when we talk about endovascular repair for the ascending as well as for the arch, we can see the challenges. Mobile portion, there is high velocity and shear stresses, and also we have the anatomic challenges that especially the proximity into the coronary ostia and to the aortic valve. And when we see the dynamic segmental anatomy, the mid-ascending and the distal ascending actually are the two portions where are more favorable to place a TEVAR. The segment of the ascending aorta that is much more challenging because there is a reverse funnel and is a little more unfavorable for aortic endograft is the proximal segment. And also, this is more than a decade ago, but we do know that there are dynamic changes in the dimension of the aortic root, and there is this variation during systole and diastole. And you can imagine that this makes it a little more challenging when we have to place a stent graft, because a stent graft must accommodate fluidity, provide seal, and of course not have any fracture. This is a report that looked at patients that they have already type A repair, and they look the anatomic feasibility. Interestingly enough, but actually expected in a way, we can see that the commercial stent grafts, anatomic feasibility for them range from 4 to 21%. But when they look if there is anatomic feasibility for valve carrying conduit, where actually you have the ascending aorta and also you incorporate the valve, then the anatomic feasibility was higher. And I think that was in a way expected, with the main limitations being the diameter of the annulus and the distance to the coronaries. And this is another report that showed again, when they look the images of patients that they had type A aortic dissection, 2/3 of them were anatomically eligible for an endo-bentall stent graft. So as a conclusion, to develop a device, this would require significant technological advancement. I think imaging, and we're going to hear more in this course regarding the importance of the imaging modalities, definitely can be extremely helpful. Of course, at the present time, we don't have any FDA available devices. Knowing the anatomic and the functional challenges is extremely important. And just a few thoughts. Something that will be a device that will be very nicely done is you're coming, as you can see here, the device is coming into the ascending aorta, deployed. Before fully deployed, you can place the stents into the coronaries and then continue with the arch endograft, as we're going to hear later on this morning. Thank you so much. It's really a great privilege to be here, and congratulate again Dr. Palma Shah for this great meeting. Thank you.